PTSD, post-traumatic stress disorder, has probably been around as long as men have fought wars, men and women. However, we first gave it a name after the end of the Vietnam War. The Diagnostic and Statistical Manual, DSM, first recognized it in 1980, about 8 years after the end of the Vietnam War. It has been well described, but it's kind of a plethora of different symptoms, and so people have argued a lot about what is PTSD and what is not. The diagnosis just changed. Going from DSM-4 to DSM-5, they added new symptoms to it. So the symptoms that have been there include flashbacks, intrusive thoughts, re-experiencing the trauma, numbness and disassociation, and that these symptoms impair you. Everybody has occasional intrusive thought, occasional nightmare, but this is bad for you and your relationships. The changes, which took place almost 2 years ago, but are really just getting implemented in this last year, the changes include adding physical reactions, somatic reactions, adding sleep problems, which is really good because everybody who comes back from deployment and most people who come home from a trauma of some sort have problems with sleep. It also adds anger and irritability as well as depressive symptoms. So those are changes over time. Now, one of the questions always is PTSD different for women than for men? And yes and no. So traditionally we've looked at PTSD in men from combat, specifically from Vietnam, while in women it's been studied more after sexual assault. And actually PTSD after sexual assault is probably worse. Why? If you go to combat, you know you're going to combat, you're prepared for it, you're trained, you've got your buddies, you've got your weapons, it's kind of exciting. And you may develop symptoms later on, especially if you've seen a lot of dead bodies or been threatened or seen your buddies blow up, which unfortunately is way too common. But a woman who's sexually assaulted, often she's unprepared for the sexual assault. It's very, very intrusive, obviously, and she may well feel very embarrassed or ashamed. She doesn't have any parades when she comes home. Now, what's changing over time, and we don't yet know where it will end up, is what about women in combat? Because they, like the men who go to war, are prepared for it and trained for it. And we don't know whether their symptoms are going to be more like male soldiers or more like civilian women. I suspect it will be somewhere in the middle, especially as, unfortunately, too commonly, often women have experienced both sexual assault and combat. This becomes important in the treatment of PTSD as well. We don't know nearly enough about the differences in how you should treat the different genders. So, for example, we have evidence-based treatments for both men and women. They are either psychotherapy and what's called cognitive processing therapy and exposure therapy, a variation of that, virtual reality. But we don't know who responds better to which. We also know that PTSD responds to medications, especially the mild, safe antidepressants known as SSRIs, selective serotonin reuptake inhibitors. That's paroxetine, Paxil, sertraline, Zoloft. Those are the FDA-approved ones, but just about all of the SSRIs are used effectively to treat PTSD. Having said that, both of those treatments have unacceptable side effects for many patients. For the evidence-based psychotherapy, many soldiers and others, by soldiers I mean Army, Navy, Marines, all the service members, many service members don't want to talk over and over about the trauma, so they drop out of treatment. And the problem with some of the SSRIs is they commonly cause sexual side effects. Delayed ejaculation, erectile dysfunction, loss of libido, and so again people drop out of treatment. They often don't tell their doctor they're having problems, they just don't come back. It's critically important that the doctor or other medical professional ask about sexual health. So because of these problems, I've gotten very interested in some of the so-called complementary and alternative medicines or innovative therapies, such as acupuncture, which has been used for pain in some people, is very effective for PTSD, post-traumatic stress disorder. There's work being done with yoga, being done with art therapy, so you don't have to talk about what happened. You can express your feelings in other ways. Writing therapy. There's a new one called stellate ganglion block, which is an anesthetic technique where you actually inject a little bit of lidocaine into the cervical ganglion. Again, it was used for pain initially, and some people with real severe and chronic PTSD found that it really helped their PTSD. There is not yet good research on these new and innovative therapies, and they by and large are not covered by insurance. It can be hard to find somebody who does stellate ganglion block, for example, so we've got a ways to go, but I think it's really important that we pursue some of these avenues because the conventional PTSD treatments are unacceptable to some people. And the other thing we need to do, again, is find out which treatments work in which genders, which people in general. The Army has done a really terrific job of surveying soldiers in Iraq and Afghanistan in combat. And it's done it over a series of years with a series of reports that are known as mental health advisory teams, referred to as the MHATs. So they have surveyed soldiers about anxiety, depression, PTSD, and other issues such as barriers to care, stigma. Could you go see a mental health provider if you wanted to? And that's a rich data source, and it's available publicly on the web, on the internet. Just Google MHAT, Mental Health Advisory Team, and their MHATs 1 through 7. And a couple of those reports have looked specifically at women. One, for example, MHAT 2, early in the war, looked at women and men, and they found almost the same rate of PTSD in men and women. Now that's surprising because in the civilian world, the rate of PTSD in women is twice as high as it is in men. Well, here in both men and women, it was about 12%. This is early on in the year. This was early on in the wars. The rate of PTSD has gone up over time as the soldiers have deployed over and over. So why is it that the rate of PTSD symptoms is about the same in male and female soldiers? We don't know for sure. My hypothesis is that women who go to war are a very self-motivated, resilient group of women. You know, most women who join the military still are somewhat unconventional. I will include myself in that category. And we're also pretty resilient folks. So I think that's why the rate is so similar. In addition, as I mentioned before, sexual assault is really devastating. So if you have PTSD symptoms from sexual assault, as is true with most civilian women, then that's probably harder to work through than having been in combat. There are stressors that have been asked about every MHAT, every mental health advisory team, and you can track them as the wars got worse and then slowly wound down. They include coming under fire, seeing dead bodies, being shot at and mortared at as two different things, returning fire, and get at the sense of vulnerability that some people have, and also seeing dead bodies, seeing your buddies blown up.